good evening, everyone. I'm back with some questions. So I have some step 1 questions here selected. These are all cardiology questions tonight. So some cardiopathophys, some cardio pharmacology. I tried changing up the format a bit and seeing if this might help. Kind of being able to visualize it and follow along with the practice questions. So again, we'll do it the same exact format. So if you think you know the answer, you could throw it in the chat, and then we're going to go over it together as well, read through it, and hopefully learn some things. So again, these are all going to be cardiology questions today. So again, we'll get started in just a second, and then hopefully we'll learn a lot of cardiology today. These are step 1 questions for tonight, but I want to try my best to incorporate some step 2 stuff, some step 3 things, and we'll hopefully learn. Okay. So if you think you know the answer, throw it in the chat, and we will go over it together in just a minute. So like I said, these are all cardiology questions. So if you have any cardio related questions, any topics that you want to talk about outside of the practice questions I have, we can do probably some rapid fire algorithms, things that I love to do, and you know, anywhere in cardiology. So let's keep tonight the theme for cardio. Ishbi, welcome. So I want to do all things cardiology today. And again, it could be step 1 material with cardio. It could be step 2 stuff. If you want to talk about some management stuff, if you're studying for step 2 or step 3, I want to just hopefully spend a lot of time learning all things cardio today. Okay. So let's give this a chance. So I want you to answer this question. This is a combination of cardiology and it looks like microbiology, which again, marrying 2 themes together. So we're gonna learn. So if you think you know the answer, throw it in the chat, same kind of format that I've always done, and then we're gonna read through it. Okay. Let me give it in one more second if you guys want to read through it, and then we'll get started together. Okay. Okay, I see some answer choices coming in. I think I see B and A seems to be the consensus so far. Okay, I see your answer choices. Nice. Okay, so let's read through it. If you haven't been here before, the way I like to read questions is read the last sentence first, so I have an idea of what they want me to answer. So when I'm reading through the vignette, I kind of know where I'm headed. And then, so reading the last sentence, know what we're talking about, and then I'm gonna start from the top and read my way down. And I'm going to purposefully try to read every single sentence just to practice. I know in real time, real life, when you're doing questions on your own, people like to jump around. I like to keep it a little bit more methodical and organized to make sure we don't skip over anything that may be pertinent. So I know a lot of students, their complaint is like, you know, if you got the answer, just answer it, right? And sure, but I want to, you know, practice the question taking strategies as well. Okay, so enough chit chat, let's answer this question. So the last sentence is asking, the causal organism is most likely to have which of the following characteristics? So the causal organism, let me make that a little bit bigger actually. So the causal organism is going to have which of the following characteristics? Okay, so do you see what they're doing here? They're not asking you, hey, what's the bug? You have to do some work, right? We're going to figure out what the disease is, what bug is causing it, and then what are the characteristics of that bug. A lot of work they're making us do. So let's read through it. A 67-year-old woman comes to the physician because of fever, chills, myalgias, and joint pain 1 month after undergoing aortic prosthetic valve replacement due to a high-grade aortic stenosis. Okay, so she's an older female and she's having these symptoms: fevers, chills, myalgias, joint pain, and she had an aortic valve replacement. Okay, because she had aortic stenosis. She does not drink alcohol or use illicit drugs. That's great. Her temperature is 102.8 Fahrenheit, so she is febrile as well. She appears weak and lethargic. I mean, she does not look well. Physical examination shows crackles at both lung bases and a grade 2 out of 6 blowing diastolic murmur over the right sternal border. So she's got crackles in the lungs. That usually implies fluid in the lungs. And now she has this blowing diastolic murmur heard over the right sternal border. Okay, so a diastolic murmurs, you should be down to mitral and tricuspid stenosis and aortic and pulmonic regurg. Over the right sternal border, I'm looking at maybe more aortic regurg, and also her history of the surgery she had. She had an aortic valve replacement. Okay. Laboratory studies show leukocytosis and an elevated ESR. Okay. So this is talking about, oops, one moment. Let me look at the chat. Okay. Let's see. Okay, so she's got leukocytosis, that means increased WBCs, which is probably implying her fever, and ESR, it's inflammation. Okay, so the pertinent clues here is that she has a fever and a new murmur. I think I did this yesterday. Whenever you see a question with a fever and a murmur, you almost want to think of endocarditis. Okay, so we're thinking of endocarditis. I'm just putting this off on the side, don't have much room. Endocarditis. Now, what causes endocarditis in this patient? She's got a prosthetic valve. There's one bug you guys should be thinking about when somebody has a prosthetic valve, and that should be staph epidermidis. Okay, so staph epidermidis is the most common cause of endocarditis in a patient with a prosthetic valve. Okay, awesome. So Maisha, you got it right. So, okay. All right, I see kind of the chat. Okay, so for those of you guys who figured out that it was probably staph epidermidis, you'd be right. So now we want to match the characteristics to staph epidermidis, okay? And the answer here would be option B. Okay, it's novobiosin sensitive, coagulase negative cocci. If they mentioned it, right, they didn't, but just to practice, remember all staph species are also catalase positive. Nope, let me try that again. So, yeah, so catalase positive are all staph, and then staph aureus is coagulase positive, and the other staph species are coagulase negative, and that's how we got to staph epidermidis. Do you see that? All right. Good. Cool. Any questions on that? Maisha, that's a great question, right? How tips on memorizing the murmur sounds. We can definitely go over that. I think that'd be a very, very important thing to do, again, for step 1 and step 2 students, so pretty helpful. Okay. Any other questions with this one, or in general, anything with cardio? Like I said, we're going to be doing all cardio questions today. Hi, Blah, welcome. Okay. Okay, can you guys still hear me? I don't know if there's a glitch on my side. Okay, awesome. All right, so just to practice, right, do you know what option A is? Alpha hemolytic optogen sensitive diplococci. There's only one diplococcus on the gram-positive side. And it's also alpha hemolytic and optogen sensitive. Okay, awesome. For those of you guys who said Streptococcus pneumoniae, that would be right. So this is talking about strep pneumo. What is this? Option C, catalase negative cocci that grow in 6.5% saline. What would option C be describing? Nice. Enterococci. All right, just practicing some of that micro. And option D, beta hemolytic bacitracin sensitive cocci, what would that be? Okay, nice. This is going to be group A strep, okay, also known as strep pyogenes. And then what's this last one? Alpha hemolytic optogen resistant. Option E. Good. This would be Streptococcus viridans. Perfect. All right, let's do this one next. Okay, again, I'll give you, again, this is all gonna be cardio. If you guys have any questions, ask away. And then if you think you know the answer to this one, throw it in the chat. We'll give it just a second. And then we'll read it together as well. All right, I see some answers coming in. We're looking at D or F. Okay, James, you're on the right track. That's awesome. Ooh, I feel like we're split between a few options. I'm seeing E and F and D. Okay, let's read through this and let's see what's going on. So again, the last sentence in saying, which of the following is the most likely cause of this patient's cardiac findings? So, oops, most likely cause. Let's see what's happening in this guy's heart. A previously healthy 46-year-old woman comes to the physician because of progressive shortness of breath, fatigue, and chest pain during exercise for the last 6 months. Okay, so it's a middle-aged female, and she's having shortness of breath and tiredness and chest pain during exercise for the last 6 months. Again, this should be thinking of like ischemic heart disease, angina, something along those lines. But let's see. She does not smoke. That's good. Her maternal uncle had similar symptoms. They might be implying something hereditary here. Let's see. Cardiac examination shows wide splitting of S2. This is the clue we need to use. Okay, the wide splitting of the S2. Okay, what is this talking about right here? The second component of S2 is loud and best heard at the second left intercostal space. Okay. That's also telling us something. The lungs are clear to auscultation. Okay, so let's break that part down. So there's clearly some heart issue, obviously some valve problem, possibly because they're talking about an S2 split that's widened. Now, I want you to think S2 normally represents the closure of the aortic valve and the pulmonic valves. When the aortic and pulmonic valves close, you hear an S2 and there's supposed to be a split. So there's something wrong with either the aortic valve or the pulmonic valves. That's what I want you to think of without even getting into specifics. And then they said that the lungs are clear to auscultation. So that makes me think it's more of a right-sided issue, because if there's anything left-sided, it's going to back up into the lungs, and you could talk about crackles or fluid or shortness of breath or something implying that the lungs are involved. The fact that they didn't really talk about symptoms of the lungs, right? Shortness of breath isn't there. There's no crackles. I'm probably thinking more pulmonic valve problems, okay, between the two. It's more on the right side. That's how you can kind of deduce it. Now, specifically, wide splitting of S2 is usually a pulmonic stenosis, okay, or a right bundle branch block. Basically, things wrong on the right side of the heart. Okay. Cool. So, which of the following is most likely the cause of the patient's cardiac findings? So, we're going to look for something that's talking about more pulmonic stenosis. Okay, there's pulmonic stenosis, which is a resistance issue in the lungs. Nice, right? So I would probably hear for crackles for ASD. Okay. Again, they are zeroing in on the S2 split. So I'm looking at more valvular problems, right? And that's how you would rule out maybe like a hole in the heart or things. That wouldn't, yeah, ASD would. I see your point. But they're talking about wide S2 split. That's specifically pulmonic stenosis or right bundle branch block. Anyway, so now we can match it to that. So which option choice here would be talking about pulmonic stenosis? Okay, do you see I'm not looking at anything on the left side, I'm looking on the right side only. So I'm going to get rid of anything that says maybe left side, just to kind of help me narrow down things. Okay, so with the pulmonic stenosis, guys, the answer would be D, increased right ventricular afterload. I'm building up resistance in the right heart. Okay, and that's going to build up afterload in the right ventricle. Good. Perfect, James. Love it. Do you guys see in ASD, they would say fixed S2 split, not a wide split S2. It's the difference. All right. Any questions on that? Thanks, James. All right, let's go. So do you see this was actually a 4-hammer question, so quite difficult. Because it can be pretty distracting thinking of S2 split being widened versus being fixed. Those are two different things. Yeah. Let's do this one next. I'll give you guys a second to answer it, and then we'll go over it together as well. Okay, I think Top Shot thinks it's C. Zaza, I think, is saying there is it's E. Okay, David is also saying E. Okay, keep throwing it in the chat and then we'll talk about it. All right, let's read this and let's see what, oh, I think a bunch of people saying C and E. All right, let's read through it. So the last sentence is saying this patient's condition is most likely associated with which of the following cardiac anomalies. Okay, so let's figure out what condition this patient has and then connect it to the cardiac anomaly. A 5.07-pound male newborn is delivered at term to a 39-year-old woman. So almost a little over 5.5-pound baby and 39-year-old at term so far. That's fine. Examination shows a sloping forehead, a flat nasal bridge, increased interocular distance, low set ears, a protruding tongue, a single palmar crease, and an increased gap between the first and second toe. They threw a lot of details at us. Okay, so when you put it all together, the big specific things I see here is like the single palmar crease should be like throwing like bells and whistles as a diagnosis. The increased gap between the first and second toe is very particular for a condition. And then the spacing, the low set ears, flat nasal bridge are kind of more subtle clues, but all of this is describing Down syndrome, right, or trisomy 21. Okay, there are small white and brown spots in the periphery of both irises. Okay, they're just describing chromosomal issues. The abdomen is distended. An X-ray of the abdomen shows 2 large air-filled spaces in the upper quadrant. Okay, this right here, the 2 large air sacs in the upper quadrant, this is that duodenal atresia that often is seen in Down syndrome's patients as well. There you go, the double bubble sign, that's what they're describing here. Okay. So what heart issue is common in Down syndrome patients? That's essentially what they're asking us. Okay. Little olives? Yes, it is. Okay. Good. So the most common cardiac defect in trisomies, especially Down, is endocardial cushion defects. Now, the endocardial cushions, embryologically, is a bundle of tissue that gives rise to the atrial septum and the ventricular septum, okay, amongst other things. So the best answer in here, David, you're on the right track, is actually option C. Okay, not ASDs or VSDs, it could be both. Okay, so AV septal defects, atrioventricular septal defect, it's that derived from the endocardial cushions. All right. So you see how the answer would be C in figuring out this is Down syndrome. All right, any questions on that, guys? Just other buzzwords you should know. I mean, things that should come to mind for some of these other ones. PDA in newborns, they often associate that with a virus. Do you know what I'm looking for? Nice. Okay. This I'm gonna think of rubella first. Congenital rubella with the PDA. Overall, the most common non-cyanotic heart defect in babies is the VSD. This is usually the most common non-cyanotic, right? When they're not talking about in components with like syndromes or chromosomal issues. So I would think of that in more general conditions. Tetralogy of Fallot, if you remember, is a cyanotic heart condition. This is one of the 2 most common cyanotic congenital heart defects in newborns. Good. Yeah, right, with this with the George as well. Out of these option choices, which one would have a holosystolic murmur, guys? The holosystolic murmur? Nice, that's the VSD. Which one of these would have a fixed S2 split? Okay, good. That would be an ASD. Awesome. Which one of these would I hear the murmur in the infraclavicular space? In the infraclavicular space. Nice. That's the PDA. Remember the continuous machine-like murmur, PDA. Okay. This is the last one I have for today. So let's do this one and then we'll pause. Okay, so I'll give you guys a second to answer this and then we'll go over it together. Okay, so let's read that last sentence. Which of the following is the most likely trigger of this patient's ventricular contractions? So let's see what's going on. A trigger for something. A 56-year-old man comes to the emergency department for chest pain that started 1 hour ago. All right, so a middle-aged male who's having chest pains. Remember, number 1, MI. Number 2, dissection. Number 3, angina. Those are the big 3 you want to start with. Let's see which one he has or if it's none of those 3. He has a history of hypertension, hyperlipidemia, and type 2 diabetes mellitus, all risk factors for a cardiac disease. He appears diaphoretic and distressed. Okay, so he's sweating and looks distressed. And ECG shows P waves independent of QRS complexes. So they're implying P waves are doing their own thing and the QRSs are doing their own thing. And the QRS interval is 0.11 seconds with normal morphology. Okay, so when they say there's a separation of the P waves and the QRSs, that is a huge hint for something. I want you to think the P waves usually represent atrial atrial depolarizations and contractions, and the QRS is more with ventricular. So P wave specifically is atrial depolarization. QRS complex is ventricular depolarizations. So we basically separated the atria depolarizing from what the ventricles are doing. They're all doing their own things. They're not communicating. So what is that anatomical structure that's supposed to be kind of the bridge between the atria and the ventricles? Good, right? So this is probably talking about complete blockage of the atria and the ventricles. It's a complete AV block or a 3rd degree heart block. Okay, so if you remember the anatomy of it, the one that severs, the one that's supposed to communicate between the atria and the ventricles, physically, right, kind of crossing the border, so to say, is the bundle of His. So option C, for those of you who said that, that would be correct. I don't think they gave AV node here. Left bundle, ectopic atrial, back bundle, sinoatrial. Yeah, they didn't give AV node on purpose because that node also communicates. The AV node is physically in the atrial side, but it communicates with the ventricles. So it's kind of like a close second. So bundle of His is kind of like it literally physically bridges over the atria and the ventricles over the septum. Sally, yeah. So they're saying P waves independent. Okay. Any questions on that? Maisha, they would have to tell you it's a specific QRS problem only. But yes, in that case, yes. They wouldn't just word it as like a separation of the P waves and the QRS complexes. Can you go over the other answers? Sure. Just remember the pacemaker of the heart is the SA node. This is the sinoatrial node is located in the right atrium, kind of at the junction between the SVC and the IVC, superior and inferior vena cava. Okay. Bachman bundle is very low yield. You don't really need to know that. It's a bundle that communicates between the left and the right atrium. So the atria communicating with each other. You probably won't see too many questions on that. Purkinje fibers are the ones running through the ventricles and eventually will split into the left and right bundle branches, but they're in the ventricles specifically. Left bundle branch is what derives from the Purkinje fibers and goes into the left side of the left ventricle. Okay, and ectopic atrial focus, let's talk about like an ectopic site sending off signals. Okay, so this would be examples of like a PSVT or AVRT, AVNRT. Those would be like when you have like an extra ectopic site, maybe Wolff-Parkinson-White syndrome would be an example of an ectopic atrial focus, like the bundle of Kent. Okay. Yeah, blah, perfect. So that would help separate those. Good. Any questions on that? All right. So we're going to keep that as the last question for the night. I do have to step away for a little bit, but I am planning to come back live in just a little bit, and I think we'll do some algorithms, right? Some rapid fire high yield algorithms that I've done in the past, and go over some big cardio stuff. And I think one of you guys had requested going over the different murmurs and how to recognize their description, so maybe we can do that. Sorry, just a little confused, Sally. Can I answer something for you? What confused you? All right, thanks, user 111. I just have to step away and do some stuff with family, and then I'll be right back. Can it be answer choice F? Ectopic atrial foci? No. What that does, if you remember, right? The best example for that would be Wolff-Parkinson-White, and that what happens is you're sending a normal signal through the SA and AV node, but then you're also sending an ectopic signal, okay? And so you have two signals being received by the ventricles, and that kind of widens the QRS and causes a slurring of that Q wave, which they call the delta wave. So they won't talk about independent P, because it's implying that the P wave and the QRS morphology in this question is normal. They're just independent of each other. Okay. The ectopic atrial foci would change the QRS. Thanks, Maisha. Richard, I did a few. Did I only do two? We did one. Yeah, we did 1, 2, 3, 4 questions. I just have to run, and then I'll be back, honestly, within like 10, 15 minutes, guys. Yeah, the wording is a little weird. Thanks, Little Olives. I do this every day. Oh, sure, Richard. Yeah, so this was the one we did just before. Yeah, guys, come back in like 10, 15 minutes if you're still free. I want to do some algorithms with you. Oh, thanks, Kayaniki. I think this is the first, this is the first question we did for tonight. All right, guys. Thanks, Ishbi. Yes, we're gonna do cardiology stuff. One of you guys had requested going over the murmurs. I want to kind of just quiz you guys, kind of one-sided here, and draw an algorithm and maybe go over the murmurs, the maneuvers, some high yield, most common presentations. But I'll see you guys in 10, 15 minutes. I just have to take care of a couple of errands and I'll be right back. Okay, see you guys in a bit.